Next speaker is Dr. Jagadesh Reddy, heading the Cataract Department at LVPR Hyderabad, and he's going to give us a crisp talk on incorporating posterior corneal power in our IOL power calculations. On to you, Dr. Jagadesh. We want to see you too.
Yeah, very good to see.
Yes. On to you. You unmute yourself, yeah.
Yeah, I've unmuted. Very good afternoon, and thank you, Dr. Chitra, for having me here. And hopefully the word crisp doesn't scare me here. So I'll try to cover in the next few minutes. So I'll be talking to you all on incorporating posterior corneal power in the IOL power calculation. So I'll be taking you through understanding the posterior corneal astigmatism, how do we measure it, and calculation of IOL power using the posterior corneal astigmatism. And do we really need to measure, or predictable ones are preferable now, and the current outcomes. So earlier, like when you look at the total corneal power or astigmatism, it's the sum of anterior and posterior corneal curvature, or the power in these two surfaces. Earlier, it was calculated assuming that the anterior curvature and posterior curvature ratio was fixed. So, but this is not true. And nowadays, we directly measure it, or we do have predictions available for IOL power calculations. So this was one of the earlier studies that has worked on posterior corneal astigmatism by Douglas Koch, and he has shown that there is certain amount of astigmatism at the back surface of the cornea, and he did put a magnitude to us from his study about 0.3 diopters. On the right of his screen, if you see majority of the astigmatism is less than 0.5 diopters at the back surface, whereas the anterior curvature can have any amount of astigmatism. And if you look at the pattern of orientation, the posterior corneal astigmatism is oriented in the majority of the times vertically, as you see here in this scatter plot. And if you look at this bar graph, on your left, you have the anterior corneal curvature orientation at different age groups. On your right, you have your posterior corneal curvature orientation. If you look, there's a stark difference here. In majority of the individuals in the posterior corneal surface, you have the astigmatism oriented vertically, and this is not true in case of anterior corneal curvature. And if you look at this table, like it is a comparison between anterior cornea and posterior cornea. If you look at the posterior cornea onto your right, the magnitude doesn't change too much. And the orientation is also pretty oriented vertically all through at different age groups, whereas there's a lot of variability in the anterior corneal surface. So with this study, it was clear that the posterior steepest meridian is always almost vertically aligned. This alignment generates against the rule astigmatism, which compensates anteriorly with the rule astigmatism and increases anterior against the rule astigmatism. PCA on average reduces the total corneal astigmatism by about 13.4%, and in about 28.8% of individuals, the total corneal astigmatism differed from the anterior corneal astigmatism only by greater than 0.5 diopters, or about 10 degrees of orientation. So in a nutshell, if you select an intraocular lens using only anterior corneal curvature measurements, it will lead to overcorrection in eyes that have with the rule astigmatism, and undercorrection of the eyes that have against the rule astigmatism. So the devices that are available for measurements, the IOL Masters 700 and the Scheimpflug imaging systems like the Pentacam, Galilei, Sirius, and the optical coherence tomography. And if you look at how these measurements compare among devices, this is a recent study that is compared between IOL Master 700 and Pentacam. Here, they do share that they're repeatable measurements, but when you want to interchange these devices, it may not be a good option. And recently, we did publish a paper comparing IOL Master 700 and Galilei in the same topic. So here we did see that total corneal power from the Galilei differed significantly from TK values from the IOL Master 700. And we also suggested that the measurements from these cannot be used interchangeably. So coming to the calculation methods, the different calculation methods that are available, and a few are as nomograms, a few are available online. I'll not be talking to you all about all these, but I'll be just taking you through Barrett toric IOL calculator from the APACRS website. Once you go to the website, once you select the IOL power calculation for the toric lenses, you'll get to this page. Once you fill all the values in that page, you'll be asked whether you want to use a predicted posterior corneal astigmatism or measured posterior corneal astigmatism. It's default predicted in all the cases. So, but if you want to change, you can always change if you have posterior corneal astigmatism measured. So once you click on the measured PCA, and it takes you to a different page wherein it'll ask you which device you've measured your posterior corneal astigmatism. You select that device and enter your posterior corneal astigmatism values here, curvature values here, and then it gives you the amount of posterior corneal astigmatism here, and then an IOL power is calculated along with an orientation of the IOL, and it does depict whether you've selected a measured PCA or a predicted PCA. So are we sure that we want to select a measured, or are we comfortable with the predicted results that we get as of today? So this is a wonderful study that just came out this month from American Journal of Ophthalmology. It has been studied in 79 patients where they looked at how the Barrett toric IOL calculator compares with predicted versus calculated, and also they compared with the most recent formula, that's the Keynes formula. Here, if you look at overall outcome, the mean absolute prediction error, median absolute prediction error were comparable among all the groups. And if you look at the percentage of eyes which were within plus or minus 0.5 diopters, they were comparable in all the groups. And if you look at with the rule astigmatism, the trend was pretty similar what we saw with the earlier slide. And the similar trend was seen even with against the rule astigmatism. So there is no variation with the rule or against the rule when you are using a predicted or a measured posterior corneal astigmatism. And in a nutshell, if you look at the outcomes in this study, so the percentage of patients who achieved half a diopter or less post-operatively, I think they were comparable in all the groups, whether it was a measured PCA or a predicted PCA. And this is one of the ongoing studies at LVPI. So for this presentation, I thought we'll just pulled out the data and we analyzed it. So here we were comparing Barrett's predicted PCA with Barrett formula with measured PCA among different devices. And we did see there was pretty comparable so far, and we are still recruiting patients. Probably we'll be able to show if there's any difference to everybody later. And in a nutshell, if you look at, we do agree at this point of time that posterior corneal astigmatism has an effect on the overall outcomes of toric IOLs. I think your threshold should be lower for toric IOL implantation in patients with against the rule astigmatism. So there's variability among devices that measure the posterior corneal astigmatism, and these values cannot be from the devices cannot be interchanged at this point of time, and we need more data if in case we want to use these devices from one across to the other. So recent results showed comparable outcomes with both predicted and measured PCA. So our calculation using online Barrett toric IOL calculator with a selection of predicted PCA appears to be a very reliable method, and that's my preferred choice as well.
Oh, that was a wonderful talk. Actually, it took care of many of the very good talk. It covered it all. But still, I would like to ask you something more for the sake of the audience. What do you feel would be the role? What is the role of posterior corneal power measurement? Is it as relevant in normal eyes as it is in post-LASIK eyes?
Absolutely, Dr. Chitra. I think as we see, it's normalized also, it plays a role, and it is shown that less amount of astigmatism on the anterior corneal surface may have lesser role, but I think as the amount of astigmatism increases, that it does play a big role. So I think it has to be taken into consideration when you are planning a toric IOL implantation in patients, even in virgin corneas.
So you do say that a mathematically derived calculation of a posterior corneal astigmatism would fare nearly as well as the total K of an IOL mass of 700 based on your analysis studies?
Yeah, at this point of time of the literature that has been published and what we saw in our experience, I think we are more comfortable in doing the predicted PCA because the measurements, the way there is variability in the measurements from devices in the posterior corneal astigmatism. So even a slight variation in the measurements can affect the outcome. It may not be the calculation system, but the value that we get can lead to an error. So at this point of time, to be on a safer side, I would err towards a predicted PCA rather than a measurable PCA.
Now we know with the Schleimpfung device, we can measure the posterior corneal part. How different would this be from the swept source OCT? Your thoughts?
Okay, so there is only, I think, a couple of papers that have looked at these values, and definitely they do well on their own. But when you're comparing, there's definitely a difference between these two, and we cannot compare these two directly. And I think they have to, it depends on your own expertise. If you're using one device, you know how much to manipulate and change your values in order to get a better outcome.
Thank you very much. That gave us a lot of information. I'm sure we know we are in the right